Welcome to a new podcast episode of Radiology AI. My name is Dania Daye, and I'm the Associate Editor for Social Media for Radiology AI. And today, my co-host Paul Yee and I are very excited to bring a new episode of the podcast series. Today, we'll be interviewing Dr. Yashasvi Tadavarthy and Dr. Harry Trivedi on their recent special report that they published in Radiology AI. The report is entitled The State of Radiology AI, Considerations for Purchase Decisions and Current Market Offerings. Dr. Tadavarthy and Dr. Trivedi, thank you for joining us today. First, I will start with a few introductions. Dr. Tadavarthy is an incoming radiology resident at Mallinckrodt Institute of Radiology at Washington University in St. Louis, and he's also the first author on the recently published special report that we're discussing today. Dr. Trivedi is the senior author on this special report, and he's an assistant professor of radiology with joint appointment in the Department of Biomedical Informatics at Emory School of Medicine. He's also the co-director of the Healthcare Innovation and Translational Informatics Lab, or HITI, at Emory. And his clinical expertise is in emergency and trauma imaging with fellowship training in musculoskeletal imaging. His research areas include the applications of machine learning to solve problems in radiology, most recently developing algorithms to improve breast cancer screening. Dr. Tadavarthy and Dr. Trivedi, thank you for joining us today. I will turn it over to my co-host, Paul, to discuss the paper.
Thank you again, Yashasvi and Hari, for joining us on the podcast. We're really excited to have you here. I always enjoy having on the podcast guests who are in different stages of their careers because of the different perspectives and experiences that different people bring, like the both of you. Yashasvi as a young radiologist in training, and Hari as an attending radiologist. Can you tell us about your background and what got you into AI and how you two started working together?
Hey, thanks for the introduction, Dania, and thank you again, Paul, for the introduction. So I'm originally from the Metro Atlanta area, and I attended Georgia Tech for college, where I studied computer science. I soon then went on to Medical College of Georgia, and I remember even before starting medical school, it was always a goal of mine to figure out how I could implement my programming background in medicine. It was actually during one of my first projects where we studied modified barium swallows, where I understood the value of programming in radiology. Later on, I learned about the work that was happening at the Emory HITI Research Lab through Emory's medical student seminar, and I was intrigued at the work that they were doing. I reached out willing to help, and they were kind enough to let me join their lab.
Great. Thanks for having us, Paul. I appreciate it. Yashasvi, or as I call him, Shez, met through an introduction from our Vice Chair of Informatics, Nabil Safdar. This was a couple of years ago, and our lab, the HITI lab, was just getting on its feet. And we were really looking for motivated and interested medical students, undergraduates, whoever was interested in the radiology AI space. And so Shez's CV came across our desk, and I had been flirting with this idea of trying to put something out that would help the casual radiologist understand where the AI space was currently and where it was headed. And so I floated this idea to Shez, and he was interested, thankfully. And so that's kind of how we started working together.
Thanks for letting us know about how you got started and working together. One of your recent projects together was a special report for the journal about the state of radiology AI in the marketplace. So as AI has received increasing attention in radiology, practices are starting to consider different options for AI software to implement clinically, both in academia and in private practice. Perhaps the first question any radiology practice should ask then, when considering purchasing AI, is, what are the motivations of being an early adopter of AI? What are some of the motivations a practice should consider, and which of these do you find personally most compelling?
So that's a great question, and it's a difficult question. The truth is there's a lot of motivation out there to adopt healthcare AI, whether it be radiology or some other healthcare facet. Things like improved patient outcome, decreasing medical legal liability by decreasing, missed findings or missed follow-up. In radiology specifically, there's a lot of burnout fatigue, so things that decrease radiologist fatigue or improve efficiency and throughput. So there really are many, many good reasons to adopt AI, and there's good solutions that kind of cover most of these. And if you didn't have to worry about the economics of healthcare, the truth is practices could benefit from all of these applications. But the reality is that healthcare dollars are really tight in general, and even more so after the COVID-19 pandemic. So the question is, how do you justify the cost or the ROI for a software to the radiology practice or to the hospital system? And the answer is really, with the exception of a few companies that make AI detection models for acute stroke, which was recently approved for reimbursement. There's a CPT code given. There's really no other insurance reimbursement for many of the other diagnostic and non-diagnostic radiology AI software out there, which means that a practice needs a financial incentive to purchase these products. So what ends up happening is that the most palatable or the clearest path to adoption ends up being software that increases efficiency or throughput, because that can be justified in direct dollars or return on investment. The more difficult argument would be software that reduces misses or reduces missed follow-up and therefore decreases liability, but that can be a really tough argument to make.
In your article, you also discuss considerations for patient data privacy and security, including the differences between processing patient data on algorithms locally, also known as on-premises, versus on a remote server, for example, in the cloud or off-premises. Can you talk about the pros and cons of each option? And do you have a recommendation for how to navigate these different options from the point of view of a radiology department?
Sure. So the truth is, each department has to make this decision independently, depending on what their needs are, what the size of the department is, what their volume is, their risk profile, their IS support, and their existing infrastructure. Most software that I have seen and companies that I have worked with prefer to go the cloud route. And that's with the caveat that this is speaking from experience at large academic institutions or large private practices that deal in large hospital systems, right? So that the answer may be different for a small practice with maybe only 10 radiologists and the 1/10 of the volume of a large academic center. But with regards to the cloud route, there are some advantages. There's lower upfront cost. You don't have to purchase hardware. There's increased scalability. So as volume increases, or let's say that you have an algorithm that detects fractures that's only being used by one division on certain types of studies, and the next year everybody wants it, you can scale it much more easily if it's in the cloud, right? You can spin up more instances, more GPUs. And it's easier to upgrade the software and maintain, right? Nobody has to be local to get things working if something breaks down. The downside of doing things in the cloud is that it necessitates full de-identification of data before it's sent for processing. But from my experience, I think most companies do have satisfactory solutions for this. Now, the flip side to this is the on-prem solutions, which in theory do provide slightly more safety, since you don't have to open up a port in the firewall to communicate with the company's server, and the patient data never leaves. But the downside of on-prem is hardware is expensive. It requires locations, server rooms, power, redundant power, redundant storage, cooling, maintenance, upgrades, all these things. That is not as easily expandable when the need arises. And it's also more expensive upfront. Requires, I think, a bigger team to maintain, may require somebody from the company to fly in and come on site. So I think the cloud option is a little bit lower barrier to entry, but again, I would say that it really depends a lot on the individual institution. And the things I mentioned are the things to consider when you are evaluating one option versus the other.
So there's clearly a lot of different factors to consider, and a lot of different areas that I think go beyond the traditional radiology clinical considerations, whether it's hardware and software considerations, as you mentioned, figuring out how to integrate things clinically. So one thing that comes to mind for me is, who's best situated to lead this kind of evaluation and decision making? Some obvious possibilities to me are maybe a vice chair of informatics or maybe a director of IT. But I think that's something that I've even observed as some of the practices I've been involved with are starting to consider using AI. So I don't know if you have any suggestions or thoughts on who might be best situated to coordinate all of these different moving parts.
Yeah, that's a great question. The interesting thing is that I think the decision of whether or not to purchase a piece of AI software or use AI is no different than the decision to purchase any other piece of software that we use in the department, whether it's our cloud dictation software or the EMR. Those are pretty big ticket items, but let's say there's a smaller reconstruction software that one division wants to use. So there's nothing unique particularly to AI software besides that it's kind of a buzzword and maybe people understand it a little bit less because it does more diagnostic related work than the software that we're used to. When I came to Emory, I kind of learned this term, which was, the champion of a project, right? Every project needs a champion. And I think onboarding or getting radiology AI software is no exception to that. So I think the biggest mistake that I've seen so far, whether it be for AI software or even our own research projects, is not getting stakeholders engaged early enough and getting too far down the road and getting excited or wanting something or trying to do something and then kind of hitting a wall when you start getting the other people that you need involved. So let's say we're really excited about a software we saw at the RSNA and we start having conversations, a few radiologists start having conversations with the company and a couple demos, and the company agrees to give us, let's say a couple of presentations, the company agrees to give us a free demo. And you spend 6 months of your time and their time, and then, you go to IS 6 months later, you go to your vice chair and they say, well, we don't have the budget, or this software, the way they're doing it is incompatible with our security infrastructure, whatever it might be, right? That's the position you don't want to get. So what I think, there's no right answer, but I think the way that it should be done is because the end user is the clinician. I think everybody would agree that you have to make, and by clinician, I mean radiologist. Everyone would agree that the radiologist has to want the software and like it. And once you have seen a couple demos and had a chance to play with it, and talk to some people from the company, the very next thing I would do is find a small group of a few radiologists in your division or your department who are really interested and motivated to get this software in. And I would take that small group and I would go then to IS and go to informatics and go to your departmental chair and plead your case, right? We discussed earlier already that software is expensive and budgets are not unlimited. So when I say plead your case, you really, I think, need to justify why the software is worth purchasing, what advantages it will have, what potential disadvantages, and then really start investigating the feasibility of it, both financially, from an infrastructure perspective, all the things we talked about, and then remain engaged throughout the process, right? The champion is responsible for hopefully driving things forward continually and moving the needle forward, and making sure things don't get stalled, but it shouldn't happen in a vacuum. And I think the main take home message would be to get everybody who's going to be involved in the purchase or the implementation, get them involved early and make sure that you're not going to hit any, so to speak, showstoppers, right? So that you don't end up wasting a lot of time.
Let's talk about the state of radiology AI in the marketplace. In your article, your team reviewed the current AI products available as of November 2019, and you found a total of 119 software offerings from 55 companies. But of these, only 46 were FDA or CE approved. What does this mean if the AI products are available or offered, but not approved by the FDA? Can radiology practices purchase them and use them maybe on an experimental or research basis?
So yeah, that's correct. So the way we aggregated these products is by collecting all of the vendors that have marketed through radiology conferences, such as RSNA and SIM, and by researching associated companies that publicly release their product information online. So of those products that are neither FDA or CE approved, the majority can be used as research tools or on an experimental basis inside the hospital, but not for patient care. So some we did not include if they were pending regulatory approval. And if we were to release an updated list, it would likely show multiple new CE and FDA approvals. Other products that we did not include as part of this original release include those products that show partnership with hospitals in countries other than US and Europe. And some of these examples are in China, Japan, and Korea. This is because the regulatory clearance in Europe or the US, it actually doesn't follow a predictable pattern following approval in Asia, whereas approval in Europe usually precedes approval in the US.
I think that's really interesting that there's this difference in relationship between CE approval in Europe versus approval in other countries, like in Asia. Based on your review, well, actually, I don't think this is part of your initial review, but based on your gestalt, do you feel like these other countries, whether in Europe or Asia or other parts of the world, are approving these algorithms at a quicker rate than the US?
So I don't think Asian regulatory markets are accepting any algorithms faster or that they have any easier requirements per se. I think one of the things is that, at least from what I've seen, the companies from that part of the world tend to focus on their own populations first and partner with local hospitals to test their algorithms. Since the population over there is so large just by pure numbers, they have so much more data and potential with their own hospital systems that they might not even need to shift their focus on the Europe population or the US. Some of the few companies that I've seen from East Asia that have FDA approval are very well developed by the time that they reach here.
You also found that although a variety of task types were addressed by the software available, a plurality focused on nodule detection on chest CT and 2D mammography with very little focus in pediatrics and nuclear medicine. Do you have any thoughts on why there's an imbalance in the current AI software offerings, both with terms of the tasks addressed as well as the specialties addressed?
Sure. I think it's multifactorial and it comes down to mainly a supply and demand. So on the supply side, we're seeing models being created for modalities where there are free publicly available datasets, such as lung CTs or even brain MRIs. On the demand side, we're seeing software being created for modalities and exam types that are either very common, very time consuming, or very tedious, or a combination of the above. Both lung CT nodule detection and 2D mammography are meeting at least one of these criteria. If I'm an AI company making software, I'm going to want to build something that either has relatively low cost of creation in terms of data acquisition and model development, or more likely, something that has high demand, which translates into high sales. You do this by first focusing on software that all practices need or want. We may see less common modalities and exam types follow in the next 5 to 10 years, but that will really depend on how things go for the first wave of software in terms of sales, adoption, and reimbursement. Otherwise, it might not make sense to create software for the less common exam types.
Yeah, thanks for that insight. One thing that just came to me is that's a little surprising is that there aren't more products out there for chest radiographs. We've seen with the NIH chest X-ray data set back in 2017 and followed by a bunch of really large public data sets, whether it's from Stanford with the Chexpert data set or from the Beth Israel Deaconess with MIT with Mimic. Do you have any thoughts on why, despite having so much data out there in excess of 500,000 images, that there aren't more chest X-ray models? Because I would have actually thought it would have been more geared towards that modality.
Right. So I think a lot of these companies that are making models based on chest X-rays, they're doing several different use cases in a chest X-ray. So when we were counting different companies that were kind of targeting the chest X-ray, if you did both pneumonia, pneumothorax, rib fracture, or other use cases in a chest X-ray, all of those were counted as one chest X-ray application. Whereas, you have different data sets for pneumonia, different data sets for pneumothorax, things like that. So I think that's one reason why you don't see as many numbers in the chest X-ray data set.
And I think one other thing just to add to that is that it may be a demand issue, right? One of the things that I learned was you can make a knockout algorithm. For example, there's a ton of great bone age algorithms, right, that perform really well, better than radiologists. And I actually, better than radiologists buzzword gets thrown around so much, it can be a little bit frustrating. But bone age might be one of those things where performance is on par or better than a radiologist, looking up an atlas. but there's not a lot of sales in the US because there's not a lot of bone age studies done in the US compared to countries in Asia. And chest x-ray, although there's a ton of studies that are done in the US, we don't have a shortage of radiologists that can read chest x-rays. And again, this comes back to ROI, right? If the reimbursement for chest x-ray is relatively low compared to other exams, and the cost of software costs just as much to develop a piece of software that reads chest x-rays as it does for mammograms or head CT or anything else, right? It's not like it's significantly easier or less expensive. So I think companies in that space run up against a demand issue where it may be that they're not finding customers that are willing to pay the price for something, for a piece of software that they think they can get through pretty easily. It can read a chest x-ray in 20 seconds or 30 seconds or whatever it might be. They may just not feel like they need it. And then I think the other challenge is that everybody realizes that the chest x-ray models that I've seen out there, either diagnose a few things, pneumonia and cardiomegaly and those things, or they diagnose 50 different things with varying degrees of performance and accuracy. And I guess one of the things I realize that maybe a lot of radiologists realize is there's so much more on a chest x-ray than even these finite lists of diagnoses that these companies are able to come up with and diagnose. And so it doesn't bypass the need for a radiologist to still really examine it. And the flip side of that is something like mammography, where 99 out of 100 times you're looking for one thing. You're looking for malignancy or suspicious lesion. On chest x-ray, you're not looking for one thing, right? You're looking for dozens of things. I mean, we could all sit and make a very long list. And so there are quite a few software packages. I mean, it's definitely in the top quartile of available software in terms of sheer number of products, but have not yet heard or seen of major, from my limited sample size, major academic centers or hospital systems using this. And that could be one of the reasons, is that they're just the groups don't feel like they have a need for it.
Yeah, I think that's a really, really important point to emphasize, that the ROI has got to be there. I recall a Twitter poll that Dr. Khan Siddiqui made out to radiologists, asking them how much they would pay per study to have an AI basically overread or maybe prelim report a chest x-ray. And I think the results were pretty astounding, that most would basically pay nothing, because they're like, listen, I can look at this in less than a minute, just do the report myself.
Mm-hmm. I kind of agree. I would pay very little, I think. And that's not to disparage the quality of the software out there, but I think there's certain things we find, if you ask the same question for, lung nodule follow-up, I bet you'd get a very different answer, right? Because we find that as radiologists, we find it tedious and difficult and not operating at the top of our skill level. And you get a very different answer, I think, if you ask that same question for something that could prelim your lung nodule follow-up studies. So I think companies have to understand that, AI is a hammer, but you can't just turn everything into a nail.
Yeah, totally. So speaking of companies, your review also focused on specific algorithms marketed by AI companies. But I've noticed that many PACS software offered by large companies like Carestream and Siemens do appear to have automated software for tasks ranging from nodule detection to tumor segmentation that's already built in. And ostensibly, these are using some form of machine learning, most likely deep learning. So were these included in your review? And if not, is it possible that there are more AI algorithms actually available for actual clinical use than many people may realize?
Yeah, so we did include these in our review. However, we do acknowledge that the collection of products in our report is only a cross-section of the total products out there. It actually may not be totally exhaustive. If there was not information publicly available to the layperson, we didn't report on it. And at the time of the publication, integration with these large vendors was not as commonplace as it is now. And we're actually seeing that vendors either create their own internal solution and load it onto their own hardware. And sometimes they'll even buy smaller AI companies and integrate it onto their hardware. And sometimes this serves as a product differentiator for these companies. But right now, I think that undoubtedly there are several more AI algorithms that are currently available. And actually, the ACR also maintains a list on their website that is frequently updated. And we also have a list on our website at hidi-lab.org.
As a follow-up question to that, you mentioned that there's different, I guess, avenues for these companies of actually bringing software solutions to the radiologist, whether that be loading smaller companies' algorithms onto their platforms. I'm thinking of platforms like Blackbird or maybe Eureka AI from Terra Recon, or potentially just placing it within a PAC software itself. Do you have any thoughts on what might be the predominant method for actually bringing these algorithms to the workstation?
I'll tell you what I would like to see. I would like to see vendors either tightly integrate models into their PACS viewers or offer libraries and APIs to allow third-party vendors to do the same, right? I think, but such a huge limiting factor right now in adoption is that you basically have two options right now. Well, you have three options. You do have the relatively few limited pieces of AI software that are directly integrated into the vendor software. They just package it in. And that's great. That's actually the desired route, because you get to interact with the model results directly. It shows up kind of natively. If it's a lung nodule detection model and it detects a nodule that you don't agree with, you can just go and delete that ROI or delete the object or what, however they just decide to display it. And so you don't get anything on your image and saved in the study that you don't want. So that's the desired, optimal outcome. The two most common methods right now are upload the series or the images to a cloud server by the company, make the markup on the image and send the series or images back down. And the problem with that is you have all of your AI markup hard-coded onto the image. Number one, it clutters the image, and it either requires you to do a side-by-side view of the original series plus the marked up series. You can get around that, fine. But the biggest challenge that nobody's really has an answer to yet, and neither do I, is that what is the medical legal implication of that? If some AI software marks up something and says, hey, I think this is a suspicious finding, and it's hard coded onto a screenshot or screen save of the image, and you choose not, you disagree, which is your purview, and you choose not to report on it, then what happens now if that ends up being a cancer, right? And that's now open to discovery, some hard-coded image or some hard-coded mark. So I think that's a rare, potentially rare but very important consequence. It's clunky to work with. And then the third option is you have to use the AI company's own software, right? So a lot of AI companies, well, not a lot, but many are making their own platforms and making their own viewers and integrating all their tools into those viewers. And they're pretty good. Most of them that I've seen are web-based. They work well. They're really thin, light clients. But then, to use those, you either have to have your native packs and then launch this separate software again, even if it's in a web browser. You have to launch something separate to get it to use the model that you want. So you get doing a lot of switching back and forth. Or you have to convince your department or hospital to switch PACS viewers to this company's viewer, which is a massive, massive lift, especially if it's a big department and it's a relatively new AI company, which all of them are, right? So what I really hope to see is that PACS vendors, PACS, people that make the software and the hardware, that there's probably less than 10 vendors that are, covering 90% of the country, that these guys make their viewers accessible via APIs or libraries so that you can integrate results into these model results, natively, so people can interact with them. That's what I really hope to see.
Yeah, thanks for sharing your thoughts, Hari. I think there's a lot of moving parts to figure out. It's going to be exciting to see what happens in the future. So your original review was back in November 2019. So fast forward to June 2021, there's undoubtedly more AI software for radiology that's FDA approved and even more available on the market. So what AI software offerings are you most excited about currently?
I'm biased. I do a lot of research in mammography. Mammography is somewhat unique in that it's an outlier in terms of imaging studies. And what I mean by that is just by sheer volume, right? 40 million mammograms are done annually. I don't know how many chest x-rays are done annually, but I would argue, mammography is either neck and neck or slightly ahead or slightly behind. And mammography is also unique in that, unlike a lot of other imaging studies, 99.2% of mammograms are negative, right? So if you have 1,000 screening studies, 8 of them have cancer, the other 992 are negative, right? And so, 1,000 women get screened, 100 women get recalled for further follow-up imaging. Of those 100 women, about 40 get biopsied, and then of those 40, about 8 have cancer, right? So there's so many points in the process at which you could bring an AI model to improve performance. You could use it to decrease recall rates and call back fewer women. You can use it to analyze a suspicious BI-RADS4 lesion and say, hey, well, I really don't think this is that suspicious. I don't think you need to biopsy it and decrease the biopsy rate. You can even get more fancy, and you can maybe start trying to differentiate invasive versus non-invasive cancers, things that need to be resected versus things that maybe just can be watched, right? So the mammography market, both 2D and now tomosynthesis is becoming more popular, is massive, in my opinion. Massive size, massive dollars spent annually on mammography, massive healthcare implications for women. And I really hope that, within the next decade, that we do have software that will substantially move the needle. The thing is, even if you change performance by 1 or 2% and you multiply that up, you're talking about hundreds of thousands of women that don't get recall imaging or don't get biopsies, right? So you don't have to make an earth-shattering model to potentially affect hundreds of thousands of or millions of patients.
As we move into the last few minutes of our time together, I want to ask you a question that we ask all of our guests. What are you most excited about for the next decade in radiology AI or informatics?
So I'll go first here, and then I definitely want to hear what Shez has to say. So I think I alluded to a lot of this earlier. I think it's adoption, right? Our main problem, 3 or 4 years ago, it was proving that AI works. I think we agree that it works. It works really well for certain things. We also agree that it's not going to replace radiologists completely, but that it can be a valuable tool to make us better. And I want to see adoption increase. I think healthcare software is 10 to 20 years behind software that we use everywhere else in our lives, whether it's, your iPhone, your Android, even the, head unit in your car sometimes feels more efficient and advanced than some of the software we get to use in the hospital, right? And so I really want to see this seamless integration and adoption to where the software and these models can kind of think ahead and predict your next move and present you information in a way that you can digest it and use it easily. Kind of the opposite of what CAD did for mammography, where it just ended up kind of getting in the way for most people. And then I think the second area is workflow and efficiency. So, in the paper you mentioned, we really talked about diagnostic software, but there's a separate area in the radiology value chain that's currently being explored, and there's so much room for improvement there. Things from image acquisition, reconstruction algorithms that can lower the dose or lower the noise, reporting, billing, coding, protocoling, vetting exams, you name it, right? So a lot of these items are pretty straightforward and programmatic, but they have a high human capital. Some person, whether it's a radiologist or a clerk or administrator, has to sit there and do a lot of these manual tasks. And if we can use software to relieve some of that burden, it will free up dollars and people to devote to more important, nuanced, and interesting tasks that we do in the department. Well beyond what we just do as radiologists doing interpretation.
And just adding on to what Hari said just there, Now, I don't have as much experience, at least in the background sort of radiology processes that can happen. But I think as trainees that are just about to start residency, I think it'll be interesting to learn how we will be taught radiology courses in the future. I think over the next few years, 5 to 10 years, I think a lot of our radiology programs will soon be adding different courses on radiology AI. And I think, at least for me, I think it'll be important for people that are just starting out to integrate some aspect of basic training in AI. So as more and more products keep coming out, I think it'll be important to have this background just so we can understand just what's happening under the hood and troubleshoot problems if they arise. And especially with us developing our diagnostic skills over the upcoming years, we're all learning radiology skills and techniques at the same time that these AI platforms are maturing. And every year, I'm sure everyone hears it, scan volumes are going up year by year. And as the next generation of radiologists are being produced, I think we'll be best served if we can use all of these tools to our advantage. I know we alluded to this before, but user interface and simplicity is the most important thing in any of this. Several research projects out there are technically great, but to make these integrate properly into the PACS system, it has to be seamless. One of the things that I came across is these AI exchange platforms that partner with multiple different vendors. There's only a few of them out there right now, but the concept is really intriguing. These exchange platforms actually allow you to implement one application that serves as a proxy to multiple different companies. So you only have to integrate it one time. And like you already said, the integration into PACS or switching PACS, you don't have to do any of that stuff. And once you're in the practice, you can select individual modules that you want based on your needs and implement them to your heart's content.
All right. Well, I'm excited for seeing how all this develops. So we're at the end of our time here, but I want to say thank you again, both Hari and Yashasvi, for joining us here on the Radiology AI podcast. It's been a great conversation, and I'll give it back to Dania.
Thanks, Paul.
Thanks so much for having us.
Thank you, Dr. Devarthy and Dr. Trivedi, for a great discussion, and thank you for sharing with us more information about the factors that should be considered when evaluating an AI system for purchase, as well as for highlighting the current AI offerings on the market. I'm sure many of our listeners will benefit from hearing this discussion. To our listeners, thank you for tuning in to this podcast episode. Don't forget to rate, review, and subscribe to our Radiology AI podcast series on any of iTunes, Google Podcasts, or Spotify. Please stay tuned for our next episode.